Good evening, all. On behalf of Maha IIP team and Maha IIP Women's Committee, I, Dr. Jaya Shivalkar, along with Dr. Neeta Hatkar, welcome you all for this very popular and enthusiastically full program that is Tuesday Takes. Tuesday Takes, a bullet train with 6 young dynamic speakers from all zones of Maharashtra, and along with them 2 expert judges to guide them and to steer them through this journey of topic which is very important to all, that is pediatric nephrology. So to start the session, I request Dr. Gangolia sir, President Maha IIP, to welcome the guest. Dr. Gangolia sir.
Thank you, madam. Good evening and namaste to all the respected experts, dignitaries, speakers on the dais and all the viewers on the Maha IIP YouTube channel. So today is the 10th episode of Tuesday Takes. Probably this bullet train comprising of almost 12 bogies, 6 speakers, 2 moderators, 2 experts and 2 co-chairman, chairman of the Maha IIP Own Committee running, and they are running again and again, and they want to run after the 9th episode also. So today is the 10th episode. Probably I'm thinking this is the 6th day of the Mahapedicon, which is continuing, I think so. So probably that will be the last day of the Mahapedicon, Tuesday Takes. And we are looking forward to a blend of all 6 speakers from 5 different zones of Maharashtra. And also we welcome 2 great experts, Pankaj Dio, one from Navi Mumbai and one from Aurangabad. So we are looking forward to these 2 experts as well. And excellent 2 moderators, Dr. Neeta madam as well as Dr. Jayashree madam. And this all Tuesday Takes was, this was the idea of the having a short topic for in the 5 minutes to cover. And all credit goes to this Maha IIP Own Committee Chairman, Dr. Renu Bolarkar, as well as co-chairman, Dr. Sonali Sirbate, and all the 10 zonal women members of the Maha IIP Own Committee. I'm sure today's episode is all about kidney, and it's very important what is to be learned, which is because probably I feel so these are the most urine tract infections and urine infection, the reports and what's all, everything is there, and we are always in the jumbling position how to go about it. Probably this session will enlighten us. Wish each one a happy learning, and we will learn a lot from the speakers as well as the experts. Thank you very much.
Thank you, Dr. Gangolia sir. Tuesday Takes has been a very popular program, especially amongst the youngsters, and it has definitely given a lot of exposure to the new talent in their respective fields. And as well as along with the speakers, we have got excellent judges always to guide us. And so let's start the session. And it is my pleasure to invite and introduce our first judge for this Tuesday Take session, Dr. Pankaj Bhansali, who is a consultant pediatric nephrologist from Aurangabad. He has done 2 fellowships in pediatric nephrology from BJ Wadia Hospital, Mumbai, and St. John Medical College, Bangalore. He is the only pediatric nephrologist from Central Maharashtra. So we are very fortunate to have you here, sir. And I extend a warm welcome on behalf of the team.
Thank you, ma'am.
Yeah. And to start our session, we have our first speaker from Mumbai and Konkan zone, as we have speakers representing the each zone of Maharashtra. So first speaker is from Mumbai Konkan zone, Dr. Harish Parulekar from Sindhudurg. He is a consulting pediatrician and neonatologist, and at present he is President IIP Sindhudurg, and his topic is urinary tract infections. So I invite Dr. Parulekar for his session. His time is 5 minutes.
Thank you. One minute. Yeah. My name is good evening, everybody. My name is Dr. Harish Parolekar, and I'm going to speak on urinary tract infections. Definition. UTI, as the name suggests, is an infection of the urinary tract from the kidneys to the urethra and everything in between. It's predominantly a bacterial infection, but less commonly, it could be viral or fungal, especially in neonates. It is important to diagnose and treat UTIs because untreated UTI can lead to hypertension and impaired renal function later on in life. The incidence and prevalence. Urinary tract infection is common bacterial infection in infants and children, occurring in about 1 to 3% girls and 1% boys. It is more common in girls except in the first year of life. In the first year, males are 4 times more likely to get UTIs, whereas beyond that, females are 10 times more likely, or girls. Types of UTI. Pyelonephritis is infection involving the renal parenchyma and the renal pelvis. This is usually a complicated UTI. Cystitis is infection of the bladder, urethral infection. These are usually simple UTIs. Asymptomatic bacteriuria is positive urine culture without any symptoms. The etiology. UTI is caused by colonic bacteria from the perineum or the preputial flora in boys. E. coli is positive in 75 to 90% of UTIs. Gram-negative organisms like Klebsiella, Proteus, or Pseudomonas, or gram-positive like Staph saprophyticus and Enterococcus are also positive. Pathogenesis. Almost all UTIs are ascending infections in all age groups, excepting in neonates where it can be spread hematogenous route. What are the risk factors for UTIs? Female gender, uncircumcised males, VUR, voiding dysfunction, obstructive uropathy, neuropathic bladder, constipation, pinworm infestation, toilet training, wiping perineum from back to front, and urethral instrumentation. Clinical manifestations of UTI. By age, less than 1 year olds present often with nonspecific fever without focus, poor feeding, irritability, and weight loss. Older children have urinary symptoms like dysuria, increased frequency, or incontinence. Abdominal pain, flank pain, suprapubic tenderness, and fever are other symptoms. By the organ involved, pyelonephritis, high-grade fever with chills, abdominal or flank pain, malaise, nausea, vomiting, and occasionally diarrhea. Cystitis is dysuria, urgency, suprapubic pain, and malodorous urine, whereas urethritis is usually frequency of micturition. Diagnosis, as all know, urine culture is the gold standard for diagnosis. Urine collection should be clean catch midstream urine, catheterized urine or Urobac collection in non-toilet trained children, and rarely suprapubic aspiration in neonates. Urine analysis in UTIs. Pyuria more than 5 cells per high power field, leukocyte esterase and nitrates positive in a urine dipstick, mild hematuria and proteinuria. WBC cast suggests renal involvement. Urine culture, send culture samples as soon as collected. If not, refrigerate before sending. Isolation of a single organism is diagnostic. If more, it suggests contamination, repeat culture. Number of colony-forming units for a positive culture depends on sampling method. A midstream sample more than 1 lakh, catheter sample more than 50,000, and suprapubic any amount of bacteria. Renal imaging not useful in diagnosing UTI, but it is important to preventing further UTI. A KUB sonogram, DMSA scan, and MCU. After first UTI, if age is less than 1 year, do all three. 1 to 5 years, do USG and DMSA. If abnormal, do an MCU. And more than 5 years, do a USG. If abnormal, do the other two. Hospitalization for less than 1 months old, sick children, or those not responding to oral antibiotics. Inpatients are given parental antibiotic guided by culture sensitivity patterns. Third generation cephalosporins are preferred. Alternatively, an amino acid can be used. Parental therapy can be switched to oral therapy in 3 to 4 days if clinical response is good. Neonates and positive blood culture, parental antibiotics throughout for 10 to 15 days, 10 to 14 days. Complicated UTIs and neonates less than 3 months, parental antibiotics followed by oral antibiotics for 10 to 14 days. In children more than 3 months old with simple UTIs, oral drugs like cephalosporins, cotrimoxazole, or amoxicillin can be given for 7 to 10 days. Lastly, a word about recurrent UTIs. Recurrent UTIs refers to more than 2 infections in 6 months or more than 3 infections in 1 year. All recurrent UTIs need renal imaging to rule out anatomical and functional renal anomalies which could cause further UTIs. Lastly, antibiotic prophylaxis. It is long-term low-dose antibiotic used to prevent recurrent UTIs. Antibiotic prophylaxis is recommended for patients with UTIs below 1 year of age, BUR, and frequent febrile UTIs. Thank you. And thank you especially to MAHA-IIP for allotting this lecture to IIP Sindhudurg, which probably is the smallest, I think, IIP subdivision. Thank you.
Congratulations,
Thank you so
Dr. Harish, sir. Nice to
Yeah.
see you.
Yeah. Thank you, though very common topic and very vast topic covered in 5 minutes. I request Dr. Pankaj Bhansali, sir, to kindly opine.
First of all, congratulations, Purvikar sir, because within 5 minutes you have covered almost all important points required in management of UTI. Just to add on few points for practical point of view, everybody should be very clear that whenever we get fever without focus, no antibiotic shall be started before sending urine routine. Most of the guidelines have suggested if we don't have focus, don't start empirical antibiotic before getting CBC and urine routine, because almost 10% of the patients of fever without focus may have urinary tract infection as an underlying etiology. For practical purpose, generally we don't differentiate between cystitis and pyelonephritis as a point of investigations. Yes, for management it definitely differs, but from investigation point of view, when we plan sonography, MCU or DMSA, we generally don't differentiate between cystitis or acute pyelonephritis. Fungal infection, keep in mind whenever we are suspecting urinary tract infection, particularly in neonatal age, or when patient has received long-term antibiotic for maybe hospitalization, ICU stay, or any other reason. Bag sample is generally not recommended for urine culture. I think preferable is definitely clean catch midstream sample, and if not possible, if child is very small, we can consider catheterized sample, because I understand suprapubic aspiration is not very easy to convince parents and sometimes to convince ourselves. So even we can put a just feeding tube, collect sample and remove feeding tube immediately, but everything shall be under strict aseptic precautions. About investigation, sonography, sometimes most of the sonologists do not mention in detail about bladder structure. What I mean by bladder structure, how much bladder get distended with urine, what is the wall thickness, and importantly, what is post-void residual volume. So make sure that if sonologist has not written about these findings, refer back patient and get these findings, because post-void residue is a very important factor for repeated urinary tract infection, and it can be an indirect marker for a lot of diseases, maybe it reflux or maybe it neurogenic bladder. Another common surgery which most of the pediatric surgeon advise for repeated UTI is phimosis. Phimosis is recommended in very specific conditions, because few studies have shown that you need 100 circumcision to prevent one episode of urinary tract infection. So I don't think it's worth circumcising every child for UTI. So unless indicated, we shall not rush for phimosis. I think rest of the points are very well covered by Harish sir. So over to Jayashree ma'am.
Thank you, sir, for your expert opinion. So we move ahead with our second speaker, who is representing North Zone of Maharashtra, Dr. Pawan Devhare. He's from Nashik IIP. Post MD, he has fellowship in pediatric nephrology as well as fellowship in transplant nephrology. He's consultant pediatric nephrologist with Kids Kidney Clinic, as well as assistant professor in Dr. VP Medical College, Nashik. He's the only pediatric nephrologist from North Maharashtra. So we welcome Dr. Pawan Devhare, and you can start your session. His topic is nephrotic syndrome.
Sir, kindly unmute yourself. Pawan sir, kindly unmute yourself.
So thank you Maharashtra IP for inviting me to give this presenting this topic, and thank you madam for the kind introduction. So I will start my presentation. So nephrotic syndrome is like the definition of nephrotic syndrome is a child with edema should have a nephrotic range proteinuria and serum albumin less than 3 grams per deciliter. So what is nephrotic range proteinuria? It is protein. If 24-hour urine protein is checked, it should be more than 40 milligrams per meter square per hour. And the more easier way is to check a spot urine protein creatinine ratio. If it is more than 2, then it is nephrotic range proteinuria. Not necessarily that you should do 24 hours urine protein for every child. Spot UPCR is equally good. Early morning sample is preferable, but if not, then any sample is good enough. And serum albumin, when you check, it should be less than 3 grams per deciliter. Serum cholesterol should be more than 200 milligrams, and it is not an essential criteria in the definition. So then there are some other definition which everyone should be aware of. One is what is remission. So for 3 consecutive days, if the urine protein is nil, then it is called as the child has gone in remission. What is relapse? That once the child is in remission, then when we say that he is in relapse, if the urine protein creatinine ratio is more than 2, or for 3 consecutive early morning samples, the urine protein dipstick is more than 2+ or 3+. So a child who responds within 6 weeks of prednisolone treatment is called as steroid sensitive nephrotic syndrome. A child who gets more than 2 relapses in 6 months, or more than 4 or more than 4 relapses in 1 year, is called as a frequent relapser. And any child who relapses on 2 consecutive occasions and the relapse is within 2 weeks of discontinuing prednisolone, or while the child is on alternate day steroid regimen, then it is called as steroid dependent nephrotic syndrome. Steroid resistant nephrotic syndrome is after giving 6 weeks of prednisolone in adequate doses, which is 2 mg per kg, and still there is no response. Response means remission is not achieved, then it is labeled as steroid resistant nephrotic syndrome. So the causes, 95% of them are idiopathic or primary nephrotic syndrome, and 5% you can find out some secondary causes like autoimmune disease process like IgA nephropathy or SLE, infections like hepatitis B, hepatitis C or HIV, CMV, toxoplasma, though rare, they can cause nephrotic syndrome. Drugs like gold salts, penicillamine or everolimus can cause nephrotic range proteinuria, and diseases like diabetes and lymphoma can also be a rare secondary cause for nephrotic syndrome. 80 to 85% of these children, they are steroid sensitive, and 15 to 20% are steroid resistant. Of them, almost 30 to 50% are infrequent relapser, 20 to 30 are frequent relapser, and 20% are steroid dependent. History, they may present with frothy urine. Usually the edema is slow in onset, insidious in onset, starts with over the eyes, then over the legs, and then ascites. They can have associated oliguria. Rarely dysuria can be there, which could be suggestive of any UTI. Hematuria, if it's present, then it could suggest points towards a secondary cause. There can be any preceding infection. Usually the relapses occurs after any acute infection, as simple as a viral URTI or a viral fever can trigger a relapse of nephrotic syndrome. Atypical features like skin rash, joint pain points towards SLE or any autoimmune process. If the child has got abdominal pain, vomiting, lethargy, or diarrhea or dysentery, these are the pointers towards any associated abdominal infection like spontaneous bacterial peritonitis. Every child, you should weigh the child, especially if the child has got edema. You should measure the blood pressure to rule out hypertension. Look for any skin rash, examine the joints, look at the signs of cellulitis. If the child has got any fever or any tenderness, especially over the abdomen. Look for any danger signs like prolonged CRT, cold extremities, tachycardia, low volume pulses, low blood pressure, postural hypotension. These are suggestive of hypovolemia. Though it is a fluid overload state, but intravascular, they are volume depleted. That's why you always have to look for these signs. You should check urine routine, check spot urine protein creatinine ratio. In urine routine, look for any signs of look for any urine sediments like RBCs or pus cells. These are the pointers towards nephritic onset nephrotic syndrome. Check creatinine, electrolytes, serum albumin, cholesterol, renal ultrasound to look for the kidney sizes. If you are suspecting anything atypical, always check C3, C4. Atypical features means hypertension, microscopic or gross hematuria, age more than 8 years. Always check these complement C3 level, C4 level if necessary, ANA, ASO. These are the tests for nephritic onset nephrotic syndrome, not for your typical nephrotic syndrome. Red flags, any child less than 2 years of age or more than 8 years of age, this is the atypical age group. Hematuria, it can be gross as well as microscopic. Hypertension, low C3, raised creatinine, hypovolemia, severe infection. The last one is the one we should focus on. You should not miss out any infection, especially cellulitis. It rapidly spreads and patient can land up in septic shock. First thing is you should assess, manage the edema, because that is the most worrisome thing for the parents. And if you take care of the edema, the parents are happy and the child is also feeling good. So if it is a mild edema, less than 7% of body weight is increased, then just fluid restriction and salt restriction is enough. Moderate to severe edema, along with this salt and fluid restriction, start oral furosemide. If it is not responding to furosemide, add aldactone. If it is still not responding to these two, third one is metolazone. In combination with these two, it is a very potent diuretic. If these are not working, then better to indoor and give IV furosemide. And if that is also not working, you should consider giving IV albumin along with furosemide. If the child has got hypovolemia, if the patient has got hypotension, give saline boluses and consider giving IV albumin. Treatment of first episode is 2 mg per kg daily for 6 weeks, followed by 1.5 mg per kg alternate day for 6 weeks. Treatment for relapse episode, give prednisolone 2 mg per kg for daily till the remission is achieved. What is the definition of remission? 3 consecutive days the urine protein is nil. Once this is achieved, then shift to 1.5 mg per kg of prednisolone to be given on alternate day. This has to be given as a single morning dose, and it is to be given for 4 weeks. After 4 weeks, abruptly stop the steroids and discontinue the treatment. So this was for the infrequent relapser. For frequent relapser and for steroid dependent, you have to see whether there are steroid toxicity. If the relapse threshold or at the steroid threshold at which the relapse is occurring is more than 1 mg per kg, that means if when the child is on 1 mg per kg alternate day of steroids, at that dose he is developing a relapse. So this is a significant steroid toxicity can occur at this level. So you should start steroid sparing agent like levamisole or mycophenolate mofetil or cyclophosphamide. If cyclophosphamide, levamisole is not working, still the patient is getting frequent relapses, start cyclosporin or tacrolimus. These are the group of patients where referral to a pediatric nephrologist is necessary. So, thank you.
Yes, thank you for a very concise presentation. I request Dr. Pankaj Bhansali sir to give his opinion.
I think when Pawan is on the dais, I don't think I need to be on judge sport. He himself is complete nephrology in himself. He's doing excellent work at Nasik, young and enthusiastic. He has covered topic very well. It's a very big topic. Just few things I will like to emphasize. He would have, but because of shortage of time, he could not focus on that. One thing is treatment of edema. Every time we say edema is the not priority of treatment, and the drug of choice for edema is steroid. So use of diuretics should be cautious because it itself can cause problems rather than use. So unless edema is causing problem in the child, maybe opening eyes, walking, tachypnea, abdominal distension, then only diuretics should be used. Don't be very aggressive because already child is intravascularly depleted. And second and most important factor which can really harm the child are infections. I remember teachers telling what can kill in nephrotic are infections. Disease will rarely kill child. So infections take priority over treatment of nephrotic syndrome. So whenever child presents with infection, our first priority will cure infection first and then add on steroid. Don't rush to add on steroid because neither it will help in decreasing proteinuria, rather it will worsen infection and can cause significant morbidity or mortalities. Only during infection, if we have significant edema, in that scenario, I think albumin will come higher up than diuretics because already child is intravascularly compromised, and in that setting if we try to give aggressive diuretics he will go in hypotension. So maybe addition of albumin will be higher up whenever we are treating sepsis with nephrotic syndrome. There are a lot of points, but another important thing what I will like to add is infantile onset nephrotic syndrome. Whenever we see infantile onset nephrotic syndrome, don't start on steroid. It's better to take pediatric nephrology opinion there only because many of these patients will not be benefited by any immunosuppressants, and adding immunosuppression is rather causing more problem to a child who is already immunocompromised. So nephrotic at less than 1 year should be referred before considering any medicines to this child. Jayashree ma'am.
Okay. Thank you for these excellent tips. Sir, you can stop sharing so that next speaker can start sharing. Okay. I welcome Dr. Sanjay Gosavi, who is MMC observer for this session. Welcome, sir. Now our third speaker is representing the West Zone. She is Dr. Deepa Mehtre from Pune IIP. She is MD Pediatrics from Seth GS Medical College, Mumbai. She is consultant pediatrician at Siddhi Healthcare Center, New Sangvi, Pune, and she has special interest in adolescent health issues and developmental pediatrics. Welcome, Dr. Deepa Madam, and her topic is renal calculi, renal stones in children.
Hello, good evening, everyone.
Yes.
Thank you for giving me this opportunity to speak on this big platform. I'm starting my presentation, which is renal stones in children.
Your slides are visible, ma'am.
Yeah, but
Not moving?
yeah.
You can stop sharing and maybe
No,
again-
don't stop sharing.
double click.
double tap करो उसके ऊपर screen पे. Do the double tap, it will move.
Okay.
Yeah.
Okay.
Yes.
Okay. A kidney stone is a hard solid concretion, that is crystal aggregation, formed in the kidneys from hard deposit of minerals and acid salts that stick together in the concentrated urine. Kidney stones develop as a result of various metabolic disorders which affect fate of calcium and other mineral elements in body. Stones may be formed in the kidney, urinary bladder, or ureter. In pediatric population, kidney stone disease has shown significant increase in the incidence and prevalence in the recent past. Incidence rate. Urinary calculi in children account 5 to 6% of all patients with stone disease. In USA, around 1 out of 1,000 to 7,500 pediatric admissions occur due to renal calculi. Stone occurrence is higher in boys as compared to girls. Infective calculi are more common in boys under 5 years of age, and there is increased incidence of metabolic abnormalities seen in them. Race and geography also plays a vital role. Mechanism of stone formation depends on urinary volume, whether it is concentrated, diluted, pH, is it acidic, alkaline, presence of promoters and inhibitors of lithogenesis. The promoters like uric acid, alkaline pH, then cysteine present in the urine. Inhibitors are citrate, phytates, magnesium, and pyrophosphates. Then the central event in calculi is supersaturation of the urine with certain minerals, and crystallization occurs with nucleation. There are different types of calculi. The commonly seen are calcium oxalate and calcium phosphate. In 57% of them are this type. Struvite calculi, which are seen in the infective pathology if present, 24%. Uric acid calculi, 6%. Cysteine, 6%. Mixed, 2%. Endemic, 2%. And other types of 1%. Nephrocalcinosis is one of the, I would like to stress few things. Nephrolithiasis, nephrocalcinosis, and urolithiasis are the three different types of renal calculi which see of. Nephrolithiasis is the stone residing in the kidney. Nephrocalcinosis is deposit of calcium salt in the tubules, tubular epithelium, or interstitial tissue. And urolithiasis is the stone forms in the kidney, but they are located anywhere in the urinary tract, including urinary bladder. Nephrocalcinosis is the deposition of calcium as calcium oxalate or phosphate in renal parenchyma. Causes are hypercalciuria, renal tubular acidosis, medullary sponge kidney hypercalcemia, renal cortical nephrosis, and tuberculosis. Common in premature infants and hyperparathyroidism, and drugs like amphotericin and trimethoprim can also cause them. Clinical presentation. This is very important. According to age, the presentation varies. In infants, the symptoms are non-specific of like irritability, poor feeding, vomiting, low-grade fever, dysuria. Older children present with symptoms suggestive of UTI like polyuria, dysuria, voiding urgency. Hematuria is most of the times present, like microscopic or gross hematuria. Very important finding is renal angle tenderness may be present in few children. If you are suspecting renal calculi, you should check for it. Then there may be sometimes history of passage of stone or some material per urethra. It is seen in little older children or adolescents. In adolescents, they typically present with acute renal colic pain starting in the flank and radiation to the ipsilateral groin. Pointers towards history of an examination. If we are suspecting, you should always ask for family history of calculi. Some conditions like cystinuria, which is autosomal recessive disorder, gout, they are is seen in the family if family history is positive. Drugs like thiazide, diuretics, anticonvulsants, and then antiretroviral drugs, salicylates, probenicates also cause them. Conditions like IBD and cystic fibrosis, this is also some present in some patients. Urinary tract abnormalities like hydronephrosis, PU junction obstructions, bladder extrophy. These are the things where urinary stasis occurs and the stone formation is promoted. Then also ask about the history of diet, the high intake of animal protein, high intake of salt like chips, then high intake of tea, coffee, then certain nuts, spinach. Prematurity also is important factor in history, because in premature children, use of furosemide, supplements of vitamin D occur. Sometimes parenteral and enteral nutrition is given. Because of that, the stone formation is produced. Investigation is like urine routine microscopy for hematuria, pyuria, urine calcium by creat ratio if it is more than 0.2, 24-hour urine analysis for oxalate, uric acid, citrate, magnesium, sodium, phosphate, and potassium. And also the supersaturation indices of these elements, blood urea create, and compositional analysis of the expulsed stone is very important to prevent recurrence. If it is possible, you should always ask for it. Evaluation, the radiological imaging, plain abdominal x-rays, which used to be done previously in long ago, they used to pick up radio opaque stones like calcium containing stones, cysteine, and struvite stones. USG is highly sensitive, expensive, detects radiolucent stones like uric acid, cysteine. However, it cannot pick up stones less than 5 millimeter, and if the stones are located in the lower ureter, because of the gaseous shadows, they overshadow the stone. The gold standard is non-contrast spiral CT. It is highly sensitive. It identifies any pathology if present, and it identifies any small amount of stone even if it is located in the lower ureter. IVP is important for complex for finding the complex urologic. Intravenous pyelography is important for complex urologic anatomy. Now management comes like whenever patient comes, you have to find to control his pain. Acute management in the form of pain control with ketorolac, diclofenac. These are the NSAIDs. In adults, they use sometimes opioid analgesics. Then proper hydration in the and control of vomiting. There is a new remedy called as medical expulsion therapy, which is tried in older children and adolescents. It works like well in them, tamsulosin and nifedipine, particularly in older children and adolescents with the stone size of 4 millimeter to 10 millimeter. They are benefited by this medicine. The surgical management is ureteroscopic stone extractions, percutaneous nephrolithotomy, and ESWL. Now the prognosis: the size of the stone is, if it is less than 4 millimeters, it passes spontaneously 80% times. If it is between 4 to 6 millimeters, 50% times. If it is more than 6 millimeters, we need to intervene because there are 10% of chances of passing it spontaneously. Management also consists of dietary advice. You should advise low salt diet, restrict animal protein, avoidance of beverages like tea, coffee, restriction of nuts, spinach, tofu, soya, sweet potatoes, avoidance of diets like ketogenic diet, and increasing intake of juice, lemonade, blackcurrant juice, because they're rich in citrate, which helps to alkalize the urine and expulsion of the stones. Thank you.
Thank you so much, Dr. Deepa. I request Dr. Pankaj for his opinion.
To begin with, when I saw the topic of this short our session, I was worried of only two topics, how to cover in 5 minutes. One was stone and other was renal transplant. But Dr. Deepa, you have done it very well, because it's relatively big topic and difficult to decide what to pick and what not to. So only thing, the stones generally we see as an adult disease, but it is very common, particularly where we practice. Dr. Renu madam also is aware of that. In this area, we have a lot of stone diseases, and it is called a stone belt. So we have seen stones forming even at 1 year of age, presenting with obstructive uropathy, presenting with acute renal failure, quite common in that. But whenever we see renal stones, particularly more than once, every patient requires detailed evaluation, because when we thoroughly evaluate, almost 70 to 80% of these kids will have some or other, either metabolic or urological abnormality, maybe excess leak of calcium oxalate or less hypocitraturia, or sometimes reflux or obstruction somewhere. So every stone disease needs to be evaluated in detail. Sorry. Before we label it as a stone, we shall be even sure about renal stones, because sometimes increased renal echogenicity or focal echogenicity is labeled as stone, and then unnecessarily undergo a lot of investigations also. So there are few subtle sonographic findings that can help us in differentiating whether it is a stone or just an increased focal echogenicity. And important among that is acoustic shadow. Like with sonography, you will see a shadow behind stone. So make sure that we have diagnosed stone, and then we shall work it up further. Now, from investigation point of view, as Madam Dr. Deepa has said, spiral CT is gold standard, but that is good for initial pickup. Follow-up can be done on sonography. So no need to expose child repeatedly for CT scan, and even contrast CT is rarely indicated. Not to blame anybody, but we see a lot of times urologists are referring for CT scan repeatedly. Remember, one CT is somewhere around 150 200 X-rays. So much radiation is not warranted when it is not going to change our line of management. And from surgical point of view, as far as possible, open surgery shall be avoided, because in pediatric, most of them have metabolic disorders, and they are a tendency for repeated stones. So every time we try to explore, we are causing some or other damage to the kidneys. So as far as possible, ureteroscopically or percutaneous. Now we have very small catheters, mini pucks, that will harm kidney less and help removing stone. So probably for that, we will need an expert in the field, but preferably open surgery shall be avoided as far as possible. And before I stop, I really thanks Maha IAP, Dr. Jayashri Madam, and especially to Dr. Renu Borakar Madam for giving me opportunity to be on this forum. Thank you, ma'am.
Thank you, sir. Thank you for your valuable expert tips. And I thank all the speakers, Dr. Harish Parulekar, Dr. Pawan Devhare, and Dr. Deepa Madam. And to carry the session forward, I request the second moderator, Dr. Neeta Madam, to take over. Thank you.
Thank you, Jayashree Madam. Now myself, Dr. Neeta Hatkar, North Zone Coordinator for Maha IIPW Women's Committee, will move to our next session. For this, our today's judge is Dr. Pankaj Deshpande, sir, well-known nephrologist from Mumbai and Navi Mumbai. Sir is presently working as a consultant nephrologist at Hinduja Hospital, Bethne Hospital, Thane, and Vashi. Sir was in UK at various hospitals like Guy's Hospital, BCH, Cardiff for 10 years. Sir has presented various papers in Indian conferences as well as ESPN. Welcome, sir, for the next session. Our next speaker is from Vidarbha Zone, Dr. Sharvari Rathi, ma'am. Ma'am has done her MD and DNP pediatrics. Ma'am is consultant pediatrician, neonatologist, and lactation counselor in Nagpur. Today's ma'am's topic is renal hydronephrosis and VUR. Ma'am, please. Dr. Sharvari Rathi, ma'am, please.
Hello,
Yes,
everyone. Good evening. Is this visible? Yeah.
Yes, ma'am.
Yeah. Thank you, ma'am. Thank you, Jayashree ma'am, and thank you, Maha IP, for having me here today and giving me this opportunity for presenting this topic. My topic today is hydronephrosis and vesico-ureteric reflux. I practice in Nagpur and I am a consultant pediatrician and lactation counselor. So let's start. So hydronephrosis. Hydronephrosis definition, it is the dilatation of part or whole of the pelvic calyceal system of kidney due to the interruption of urine flow with accompanying atrophy of the renal parenchyma. So here we can see the dilated pelvis and the calyces in a kidney specimen. Causes of hydronephrosis, it can be primary because of the folds, pelvic junction obstruction, vesico-ureteric reflux. It can be secondary because of the calculi, infections, tumors, congenital calculi, infections, and tumors. Then it can be intraluminal, extraluminal, or it can be intramural. So intraluminal causes can be calculi, folds. Intramural causes can be strictures, tumors of the ureter. Extramural causes can be aberrant artery, lymph nodes, malignancy, retroperitoneal fibrosis.
Madam, your camera is off. We cannot see you.
Okay, ma'am.
Please on the.
Yeah. Hello, ma'am. So yes, so these are the various causes. Then the causes can also be unilateral as well as bilateral. So unilateral causes and bilateral causes will be depending on the level of the obstruction of the renal system. Okay. Presentation. A patient may be asymptomatic. Sometimes the patient may present with pain in the side of the abdomen, renal colic. Mainly the patient will present with fever, oliguria, anuria, dysuria, or increased frequency. Fever along with hematuria, vague GI symptoms. A patient may have palpable renal mass or bladder mass. There can be incomplete voiding of urine. A history and clinical examination can guide you regarding the various causes. X-ray KUB can be done to detect renal calculi. Some USG abdomen is an important investigation to detect various causes regarding renal masses, calculi. CBC, urine analysis, KFT are done. Intravenous pylography can be done to detect the renal function as well as any obstructing lesion in the renal system. CT abdomen can be done to detect the renal mass, if any renal mass present, or the calculi. Vesicocystourethropy, which is very useful to detect the vesico-ureteric reflux or any other pathology related with the urethra. DMSA scan, DTPA scan can be done to detect the renal morphology, any renal scars, or the renal function. Treatment goals for hydronephrosis is, the main treatment goal is to restart the free flow of urine. We have to relieve the pain, treating the urine infections, so that the main concern is to prevent the further damage, renal damage. Surgical intervention if required for draining the urine, percutaneous nephrostomy, dilatation of the strictures, also for the renal calculi. We can do the extracorporeal shockwave lithotripsy and now antenatal hydronephrosis. Antenatal hydronephrosis, nowadays because of the antenatal scans, most of the fetuses we diagnose antenatal hydronephrosis. Now how to go for this? The incidence here is like 50 to 70% of the hydronephrosis is transient hydronephrosis here. As the baby grows, these hydronephrosis will disappear. The most common causes are PUJ obstruction in 10 to 50% of the cases and vesico-ureteric reflux in 10 to 40% of the cases. Females have a lesser incidence as compared with males, 1% in males, and females have 0.5%. Now, there are various classifications to assess the severity of this antenatal hydronephrosis. We have mostly on the practical basis, if the renal pelvis anterior-posterior diameter is to be seen, if it is at the third trimester, these are the findings for the third trimester. If the third trimester finding is 7 to 9 mm, it is a mild hydronephrosis, antenatal hydronephrosis. If it is 10 to 15 mm, then it is classified as moderate antenatal hydronephrosis. And if it is more than 15 mm, it is classified as severe antenatal hydronephrosis. Also, there is a SFU classification and a UTD classification, which is urinary tract dilatation classification system. Now, how to go along with this? If you have found that a patient is having antenatally detected hydronephrosis, and if it is unilateral, you can go for a third trimester USG. If you have found that the fetus is having a bilateral hydronephrosis without any extra renal anomalies, you can do USG every 4 to 6 weeks. But if there are significant extra renal anomalies, you can refer them to specialized centers. Now, as soon as the baby is born, how to go for the postnatal management? If the renal pelvis AP diameter is less than 7 mm and there are no other abnormalities, you go for repeat USG every 3 to 6 months. If the renal pelvis APD diameter is 7 to 10 mm, mild to moderate, this is classified as mild to moderate hydronephrosis. You have to go along with the investigations and find out the cause regarding and treat accordingly. So renal pelvis APD diameter more than 10 mm with calyceal dilatation, renal thinning, ureter dilatation, that is classified as severe hydronephrosis. If you're suspecting a lower urinary tract obstruction, surgical correction is to be done. Antibiotic prophylaxis and MCU is also done if you are suspecting lower urinary tract obstruction in less than 48 hours. Now, vesico-ureteric reflux. Retrograde urine flow definition. Retrograde urine flow from the bladder to the upper urinary tract is known as vesico-ureteric reflux. Now, the incidence is 1 in 3. 1 in 3 children are reported to have vesico-ureteric reflux. Risk factor. Mostly girls are having a higher risk of vesico-ureteric reflux. If there is a family history, the incidence also increases. Child is in 2 years, and if the child is having bladder bowel dysfunction. Now, pathophysiology. There is an angulation at the level of trigone and the intravesical ureter part, which acts as a valve and prevents the black flow of the urine. Now, if there are high intravesical pressures or the trigone is weak, okay, and high intravesical pressure or the weak uteral musculature, then you can have a backflow of urine, which can cause high hydrostatic pressure over the kidneys and cause renal parenchymal damage. Also, neurogenic bladder can lead to vesico-ureteric reflux. Patient may present with repeated urinary tract infections, fever, pain or burning sensation on urinating, frequent urination, drop by drop urination, a feeling of incomplete bladder emptying. Now, causes. Primary view are, this is because of the anatomical and functional problems of the urinary system. Okay, and secondary view are, that can be because of the post-surgery injury or an abnormal pattern of bladder emptying. Previous infection also can lead to vesico-ureteric reflux. Grading of vesico-ureteric reflux. Grade 1, when there is reflux only into the non-dilated ureter. Grade 2, reflux into the ureter and the renal pelvis without dilatation. Grade 3, reflux with mildly dilated ureter and the pelvic callaceous system. Grade 4, reflux with the tortuous and moderately dilated ureter with blunting of the renal fornices. Grade 5 is the reflux with the tortuous and severely dilated ureter, dilatation of the pelvic calyces with loss of fornices and papillary impression. Diagnosis: ultrasound, voiding cystourethrogram, Dagmar-Capto-Succinic scintigraphy, and DTPA. Blood investigations: CBC, KFT, urine analysis. In voiding cystourethrogram, less than 6 months, we insert a catheter to the urethra, and the child is after filling the bladder, the catheter is removed, and when the bladder gets full, it voids off, and we can identify the pathologies of the lower urinary tract. In dimer-captosuccinic acid scintigraphy, we link this molecule with technetium-99 scan, and we take the X-rays. Treatment. Primary viewer. Mostly, they will get better as the child gets older. Until VUR goes away on its own, we have to treat with antibiotics. Antibiotic preferred is cephalexin, trimethoprim, sulfamethoxazole. Treating UTI quickly and preventing UTI from developing will make it less likely for your child to have a kidney infection failure. Secondary vesico-ureteral reflux, you have to treat the cause. You can do ureter reimplantation, endoscopic surgeries can be done. Antibiotics are given for treating urinary tract infection, and intermittent urinary catheterization to relieve the urinary backflow. So the main aim here is to have a to relieve the backflow and to have a one-sided antegrade urine flow to relieve the hydrostatic pressure over the kidneys. Thank you.
Thank you, ma'am, for such a nice presentation about the hydronephrosis. We get lots of hydronephrosis antenatally diagnosed, and then the anxious parents after the birth of the baby. And thank you for the VUR nicely presented. Sir, Pankaj Deshpande, sir, please opine about
Yes.
it.
A vast topic that she covered quite well in a very short time. I mean, I think as Pankaj said earlier, these are topics that require more than an hour of presentation. Just a few things for people to remember. Every antenatal scan which shows hydronephrosis, you need to look at the measurements, not just somebody saying hydronephrosis. So the simple rule is to remember in the 5th month, if the AP diameter is more than 5 millimeters, in the 7th month, if it is more than 7, and if in the 9th month it is more than 9, then you've got hydronephrosis. Now, hydronephrosis can be unilateral or bilateral, as she mentioned, but look at the Leica volume. If you have got Leica volume which is reduced, you are dealing with a more severe problem. The Leica present around the baby is basically urine that the child is passing in the antenatal period. So in the presence of oligohydramnios, you are more likely to have a severe kidney condition in the postnatal period. In the postnatal period, any diameter of the pelvis measured as AP diameter more than 10 millimeters is considered hydronephrosis. You will often find ultrasound reports telling you mild dilatation present, but the AP diameter is 7 millimeters, or mild fullness seen, which is 7 millimeters. That does not need any action because there is no hydronephrosis. Any child who's got antenatal hydronephrosis has to 100% have a postnatal ultrasound. If it is a boy, bilateral hydronephrosis within 48 hours. If it is a girl, or unilateral hydronephrosis in a boy on day 5 or day 7. Remember, very likely you will miss hydronephrosis in the first 2 days because the baby is not feeding well, and therefore the amount of urine the baby is passing is quite low. So even if hydronephrosis is present, you may miss that. It's very important for you to remember this because you may pass it off as normal because the ultrasound says normal, and the child presents 1 year later having a small shrunken kidney on one side. So the dilatation which is present, as she rightly said, puts pressure on the kidney parenchyma and the kidney function can get lost on that side. So these are important points for you to remember in terms of hydronephrosis. Any AP diameter more than 10 millimeters is hydronephrosis and needs to be taken further either by repeated ultrasounds or by investigations. In terms of reflux, which she mentioned, remember that reflux can be present in normal people also. Ethically, we are not allowed to do any studies today, but in 1977, Philip Ransley did a study in NICU babies and showed that 1% of the normal population carries reflux. Now, 1% does not go into CKD. 1% does not get urine infections. So what happens to this reflux? Reflux is an incidental finding in a lot of these people. So it's not necessary that every reflux needs to be treated or needs to be acted upon in either way. So unless it is causing damage with repeated urine infections, which are confirmed by doing appropriate tests, not just because somebody feels there are a few pus cells in the urine or a little bit of fever that is present, reflux may not need surgical intervention at all. Most of them are benign and they will not cause problems unless there is an obstructive element like posterior urethral valves, which is associated with it. I think everything else she covered well, and I think the time is up. So I think we'll stop here.
Thank you. Thank you, sir. Thank you. Thank you, ma'am. Now our next speaker is Dr. Shriram Shrirame from Marathwada zone from Nanded. Sir has done his DCH and DNB in pediatrics. Sir is consultant at Ankur Bal Rugnalaya, Nanded since last 11 years. Sir has done courses in advanced NRP and a PALS. Sir is a national faculty for the basic newborn care program of a national IRP. Welcome, sir. Sir's today's topic is a very important topic for day-to-day practice, renal transplantation. Sir, please.
Am I audible?
Yes, sir.
First of all, thank you to the MAHA-IP and Dr. Renu Puralkar madam, Dr. Neeta Hatkar madam, Dr. Pankaj Gangulia for giving me opportunity to present here. My topic is very vast and a little bit exhaustive, but I have keep it as a simple. So renal transplantation is a very much important in pediatric age group because the it has
Sriram, sir.
Yes, ma'am.
Sorry to interrupt you, but we cannot see your slides.
I have shared my slide, ma'am.
No problem, sir. You can stop sharing and I will share it for you.
Yes, ma'am.
निकाला क्या
क्या?
Yes, yes.
हाँ,
yes.
एसिड निकाल के थोड़ा सा ये किया और अभी कोई करने बोला है.
So renal transplantation is the treatment of choice for the all end stage renal diseases. So
नहीं किया, मेडिसिन का लिया उसने.
hello.
Pallavi madam, please mute others.
की देने का नाम
ऐसी बोला.
Yes, ma'am.
देखो मुझे क्या.
Hello.
Yes, sir.
Sorry for disturbance. Renal transplantation is the optimal therapy or treatment of choice for all end stage renal diseases, and we should know that renal in ESRD is defined as a decline in the renal function to an extent that life-threatening biochemical abnormalities persist despite the optimal medical management. So we all know the end stage renal disease. So when patient we entered into end stage renal disease, so we also label as a chronic renal failure, and that is when CRF progresses to the end stage renal disease. We label it as a by definition calculated creatinine clearance, which is less than 10 to 15 ml per minute per body surface area. So any patient who entered into end stage renal disease, we will consider that patient for the renal transplantation. We know that renal transplantation therapy is mainly the bridge for the diseases. Chronic dialysis leads to the life-sustaining but inferior to the renal transplant, and this renal replacement therapy is a bridge to the renal transplant. And 5-year survival rate is greater in the renal transplant than the renal replacement therapy. We know that incidence of end-stage renal diseases is about 14.4 per million population for the age of 1 to 19 years. The etiology varies with the age. Basically, between 0 to 4 years, most of the common causes for end-stage renal diseases are the congenital one. They are aplasia, hypoplasia, or dysplasia. And other causes most commonly in 4 to 10 years is basically the obstructive uropathy, that is vascular reflex or another uropathies. And in between 10 to 19 years, the most common causes for the end-stage renal diseases is focal segmental glomerulosclerosis or membranous nephropathies. Then other causes for end-stage renal diseases are the reflux nephropathy, chronic glomerulonephritis, polycystic kidney disease, medullary cystic disease, hemolytic uremic syndrome, congenital nephrotic syndrome, and familial nephritis. Next, please. So we have seen that almost all the cases who entered in the end-stage renal disease, the treatment of choice is the renal transplantation. Only few relative contraindications for the renal transplantation are the basically untreated malignancies. Patient had severe HIV infection which is not responding to the treatment. Fourth is progressive neurological diseases and severe hepatitis B and hepatitis C infection in the patient. These are the basically relative contraindications for the renal transplantations. So preemptive transplantation means that renal transplantation done prior to the dialysis, and this should be done in basically happens in 25% of all pediatric patients. Advantage of preemptive transplantation are basically lower incidence of the infections and basically low cardiovascular risk factor, and there is chances of decreased allograft rejections also. So we will consider the preemptive transplantation basically when the glomerular filtration rate is less than 10 to 15 ml per minute per body surface area, and when the symptomatic ESRD or need of dialysis is within 6 to 12 months. So pre-transplant evaluation should be done. Donor transplant evaluation and recipient evaluation should be done. We have to evaluate the causes basically, which are the common causes for the ESRD. We have to evaluate the thoroughly recipient, screen for the any contradiction that we have mentioned. We have to screen for the infections also. We have to look for the any recurrence of some diseases, that is FSGS, hemolytic uremic syndrome, MPGN, that is membranoproliferative glomerulonephritis. These are the diseases will also recur in the after the renal transplantation also. So we have to be careful during the evaluation. So we have to check for the immunization, that is hepatitis B and varicella infection. These are the common infection which will flare up after the post-transplant also. So we have to immunize the child with hepatitis B and varicella. We have to optimize the nutrition. Baby should be nutritionally well balanced, and recipient should be ABO compatible, and he or she should be negative lymphocytotoxic T cell cross match. These are the recipient evaluation. For donor evaluation, we have to do the same evaluation. We have to living related, that is parent or sibling older than 18 years. We have to screen for the any infections and other diseases also. So unrelated donors should be screened, also screened those who are emotionally bonded with the donors. And third donors are basically deceased donor. They also should be thoroughly investigated for the infections. And donor should be ABO compatible and should be negative cytotoxic cross match, and he should have HLA matching. We have to screen for the infections. We have to do the UHG abdomen, KUB, angiography, and spiral CT. Thorough evaluation should be done before the transplantation. Transplantation procedure, there are two approaches. Those patients who are less than 20 kg weight, the approach is retroperitoneal transplantation. In this approach, Renal artery and renal vein of the allograft is connected to the right side of the aorta and inferior vena cava close to the bifurcation. And those babies more than 20 kgs, the transplant procedure should be performed in the iliac fossa, and renal artery and renal vein basically connected to the common and extrailiac arteries. These are the two procedures depending upon the weight during renal transplantation. Some pre-operative, intra and post-operative care should be taken by the transplant team. Basically, fluid and electrolyte balance should be checked, and there is dyselectrolytemia before and during the treatment. After the treatment also, we have to be cautious, be careful. Some metabolic syndromes may occur, hypophosphatemia, hypocalcemia. This syndrome should be treated. Then immunosuppressive therapy is the most important therapy for the survival and chances of graft successful. Basically, two types of induction immunosuppressive therapy and maintenance immunosuppressive therapy. It's very much important, and every unit has its own protocol for induction and maintenance of immunosuppressive therapy. Anti-infective prophylaxis should be given for decrease the viral infections and decrease the bacterial infection to the recipients. We have to monitor for the complications. The most common complications are acute rejections, surgical complications, maybe vascular thrombosis, maybe their infections, flare up of infections, maybe gram-negative, gram-positive bacteria or some viral infection may also flare in the recipients. Then hypertension is also common complication. We have to treat very cautiously. Some hematological complications are also occurs in renal transplant patients, and we have to be careful and we have to treat very cautiously. Then most important is recurrence of the primary diseases in allograft. I have already mentioned that is focal segmental glomerular sclerosis, membranoproliferative diseases are also recur in the recipients of the renal transplants. So we have to take care of all these complications. So survival will be increased if we manage all the complications well. Outcome: 5-year decade their donor survival and living donor graft survival is of 78 to 84% respectively. In India, transplantation has been started in 1971, and it is now very successfully done in many centers. Not only in adults but in pediatrics, results are very good, and also many centers are doing very good works. So outcome is very good with the immunosuppressive therapy, and proper donor and recipient evaluation will lead to the chances of success of renal transplantation. Thank you all. Thank you all of you.
Thank you, Dr. Srirame sir, for such a precise presentation in a given time. Thank you, sir. I request Dr. Pankaj sir have an expert opinion about.
Okay, again, a very exhaustive topic, and I'm amazed that you have been able to cover most of it. I'm only going to talk a few practical questions that get asked to every doctor about transplantation, and often you don't know what to answer. So the first question that I would ask, and I would like somebody to tell me, is if you are going to transplant somebody whose creatinine is 5, why don't we transplant somebody when the creatinine is 2? We know that the child is going to need the transplant, so why wait? Why do we go ahead and transplant them after they reach 5? Anyone wants to answer?
Basically, that is preemptive transplantation. We know that some diseases.
No, that's not. That's a different one. The point being, what I'm trying to tell you is, because this is a question which you will get asked, why don't we do a transplant today? You know that the child is going to go into kidney failure. Why don't you transplant now? The answer very simply is in your statistics that you put up. Renal transplant is not a cure. It is just a better form of dialysis. So it lasts only for a limited period of time. So your renal transplant success, a transplant given today at 1 year, 99% kidneys work, at 5 years, 80%, and at 10 years, 70% kidneys work. 30% will need a second transplant again. So a 70-year-old man needing a transplant will get away with only one transplant. A 15-year-old boy who needs a transplant today is going to need a second transplant at 25 or 30 years of age. So if you start transplanting at 5 years of age, you're giving the second transplant even more earlier. And it becomes more and more difficult to transplant these patients. That's why we allow or we wait and get the maximum out of the original kidneys, which is where I'm coming to. Transplant is not a panacea that you jump into a transplant. We need to preserve the kidneys for a long time. And after the next talk, I will tell you why that is more important, because we miss all of them. Most of the adults who need transplant in the adolescent age group up to 30 years of age are patients who we as pediatricians have missed in the pediatric age group. Full stop. There is no other explanation for that. And that's what we need to change. That's one. Secondly, a child who needs a kidney, a 10-year-old child, can an adult donate a kidney is a very common question that gets asked. And yes, an adult can not only donate, but it's even better for an adult to donate because you are anastomosing the renal artery and the renal vein to the donor kidney. So the donor kidney's renal artery is going to be quite big. So the chances of thrombosis are much less if the donor is an adult. And that's why parents can donate, and therefore an adult can donate to a child. That's a very common question. This third thing is you have live donor transplants, as you mentioned, and cadaveric transplants. Unfortunately, in India, cadaveric transplantation is not very prominent because very few people donate their kidneys. So I think everyone here who's in the audience should make a commitment that you are going to donate your kidneys, because that's what it is. We have 3 lakh patients who need dialysis every year. And the number of kidneys that are available, if you look at a center like Mumbai, hardly 100 cadaveric transplants. That's an awfully low number of cadaveric transplants that we are doing. So we need to pick up on that. Despite awareness everywhere, that number is just not increasing. So I think these are the few points that you need to be aware of in renal transplants. Thank you.
Thank you, sir, for a nice few points added by you. Our next speaker is Dr. Vinod Ingre, sir, again from the Marathwada zone. Sir is from Aurangabad. Sir is pediatric intensivist and working as assistant professor in MGM Medical College, Aurangabad. Today's sir's topic is diagnosing renal diseases. Dr. Vinod Ingre, sir, please.
Good evening, all. I'm thankful to Maha IIP, Renu ma'am, Jayashree ma'am, Neeta ma'am for giving me this opportunity. We had a thorough discussion on renal diseases starting from UTI till renal transplant. But regarding this, what is the first and foremost thing is suspecting and diagnosing a renal disease is the first step. And it has to be done appropriately. Then only we'll be able to give a proper cure to that child. So here I'm discussing about diagnosing renal diseases. These are some obvious clinical features of renal diseases where anybody or we will are unlikely to miss the renal diseases. First is hematuria, edema mainly of facial edema, abnormalities of micturition, oliguria, foul smelling urine, dysuria. Or
please excuse me, it is not a full screen as well as slides are not moving.
1 second. Is it full screen now?
No. Okay, we can read, no problem in that. I think so. We can read, but it's not full screen. Okay, I think so. Carry on.
This is regarding subtle features where we should suspect a renal disease, and these are the features where you should not miss, or your red zone should be alerted. Enuresis, polyuria, any child with presented with a rash, child who is presenting with a stomach pain and having a pale skin. The signs which particularly.
No, it's the slides are moving now. If you find any difficulty, I will share for you if you want.
Like I will be more happy if you can share it for me.
Yes, then please share. Stop sharing. Sir, you stop sharing.
Yeah, I have stopped now.
What is the topic? Your diagnosis now?
Diagnosing renal diseases.
Okay.
So regarding signs, we need to stress upon some signs. Like if any child is coming to your busy OPD, you should make a habit of looking for the hypertension. Make a habit to look for the blood pressure of each and every child. Then only there are chances that we will miss a hypertension. Sir, is it getting on?
Yes, yes. Somebody has tried sharing in between. 1 minute, huh? Just 1 minute. You don't share now.
No,
Got it?
Yes, yes.
You keep on saying next. Yes?
Next one. Yes, okay. So I was discussing regarding hypertension. We as a pediatrician have a tendency to don't look for the BP of each and every child. If you are suspecting any renal issues, make a habit to look for the BP. Same for the growth retardation. Have a thorough check in anthropometry. Anemia, any anemia which is unexplained, it should alert you. Bony deformities, any abdominal mass should alert you. Next. For investigations, we have a long list of investigations starting from a urine routine microscopy, going for a culture, B1 creat, USG KUB, and up to like renal biopsy, MCU, DMSA. But next, what is the most important and the important thing is to go for a urine routine examination. Can you go for a next slide? Urine examination, it is easily accessible, available at everywhere, even at a grassroots level. So meticulous urine examination is the most important. For that, specimen should be a fresh and relatively concentrated. Why concentrated? Because formed elements quickly disintegrate in dilute or alkaline urine. Microscopic examination of uncentrifuged as well as centrifuge specimen should be done. Next. It should be promptly examined. Most of the time what happens, urine is sent and it is lying there for in a lab for a longer duration. It should not happen. As we discussed already, for a culture, there should be a midstream specimen and it should be taken after a careful local cleaning. In neonate and infants, suprapubic aspiration is ideal, but we try to avoid it. Whenever you're sending a culture, send immediately to the laboratory and plated within 15, and it should be plated within 15 minutes, or it should be stored at a refrigerator at 4 degrees Celsius. Why? Because bacteria multiply rapidly at a room temperature, which may give a false positive results. Coming to urine routine and microscopy, pH, routine laboratory reports of pH are of not no importance. Because why? It should be ideally collected in a capped syringe and pH should be measured. Fasting produces a low pH and the post meal have a high pH. Coming to a urine protein, proteinuria is always abnormal. If you get any time you are getting a proteinuria, you should always must find out the sort like a cause for it. Accurate collection of urine over 24 hours period is required to quantitate protein excretion. As we all know, more than 4 milligram per meter square per hour is considered as abnormal, and going for more than 40 is considered as a heavy proteinuria. dysmorphic RBCs, RBC cast indicates glomerular hematuria. If you have more than 5 neutrophils per high power field, then we think of UTI. The thing to know is 1 to 3 per cells per high power field is a common misreporting, and it does not indicate UTI. Presence of 1 lakh bacteria per ml confirms UTI, and lesser number should be correlated with a clinical evaluation. Next. Urine PC ratio, measurement of the ratio of urinary protein and urinary creatinine.
Sir, you have got muted. Please unmute yourself, sir. Yes, sir.
Yes. And generally it is done to estimate the severity of the proteinuria. Values of more than 2 indicate the heavy proteinuria, and less than 0.2 it's considered as insignificant. Such a responses are of use following the response to the therapy in various disorders, but it is not a compulsory to do each and every case of a nephrotic syndrome. Next, blood urea levels. Blood urea levels of less than 40 milligram per deciliter does not indicate a normal renal function. Why? Because in a steady state, more than 75% of GFR may decrease before urea level starts to rise. Perirenal factors readily cause rise in blood urea level. Excessive protein catabolism and absorption of blood from GI tract may lead to the transient rise in a urea level. Next, coming to a creatine is mostly derived from the metabolism of creatine. It's a bulk of which is in the muscle. Normal range for infancy 0.2 to 0.5, and for older children we consider 0.4 to 0.9. It has a various confounding factors. Dilutional effect of fluid boluses can affect it. Poor creatine production by muscles, and methodology of creatine measurement also affect it. Creatine is freely filtered. Serum creatine levels more closely reflect to the GFR. It is insensitive to early changes in GFR. It lags behind GFR changes. So we go for an estimated GFR. It gives a real idea. And how it is calculated? 0.413 into height into serum creatinine. Coming to a ICU setup, we want to, by the time there is a rise in creatinine, we have already missed the bus. So if you want to recognize the acute kidney injury in initial stages, you must go for a renal angina index. You should look for the biomarkers. As I said, by the time creatinine is lost, like creatinine is increasing, we are already in an injury phase. So early recognition, early suspicion, and appropriate test at appropriate time will prevent us from going for an acute kidney injury and chronic kidney injuries. Thank you.
Thank you, sir, for such a nice presentation. Over to Dr. Pankaj, sir, for the expert opinion.
Okay, I think we are well in time. So I just want to take 2 minutes of your time. All that he said is completely valid. But the biggest question is when and why would you do it in patients? So for example, when I was in 11th standard, खूप वर्षापूर्वी, we used to do a chemistry experiment, जिकडे copper sulfate mixed with water used to give hydrogen H2SO4. So when the professor asked की कुठलं acid तयार झाले ते H2SO4, पण H2SO4 ओरडत बाहेर येत नाही की H2SO4 आहे मी म्हणून. So you have to show that it is H2SO4. Similarly, for children, which children need this particular test is more important. Acute kidney problems are fairly simple. काहीतरी गडबड घेऊन येतो, त्याला सूज असते, लघवीत रक्त जातं, बाकी काहीतरी त्रास होतोय. But the problem is in diagnosing chronic kidney disease, which I said about renal transplant earlier. So how do you diagnose chronic kidney disease? And for that, we need to change our understanding. So chronic kidney disease is measured in terms of GFR. So any of you doing a serum creatinine, if you're doing a creatinine and not calculating the estimated GFR, please don't do a creatinine because it's useless. Okay, the estimated GFR is calculated by 0.41 multiplied by the height divided by the serum creatinine in milligram%. The normal GFR should be more than 80 ml per minute in a child more than 2 years of age. So if you calculate and you find that the GFR is low, then your alarm bell should start ringing की काहीतरी गडबड आहे, पुढे problem होणार आहे. But having said that, we need to understand, suppose your GFR, and by the way, kidneys are very silent organs. So whoever has joined this meeting, whether it is 100, 150 or 200, I am pretty sure none of you have done your creatinine in the last 1 year. If you haven't, please go and check your serum creatinine tomorrow, because you do not know what your kidney function is. If your kidney function drops by 10%, suppose your GFR instead of being 80 is 70 tomorrow, what symptoms will you see? Nothing. If it drops to 50, nothing. If you drop to 30, you will still not get any symptoms. When it drops to 20 ml per minute, the symptoms you will get are all the symptoms that you see in your pediatric OPD. Lethargy, tiredness, बरं वाटत नाही. How are you going to diagnose? There is no way of diagnosing chronic kidney disease. So our thought process has to change. Chronic kidney disease children are not sick children. They are normal children attending school. So that's why a serum creatinine has to be done regularly in every normal child also. Without that, you are never going to pick these children up, and you are going to keep on pushing. And when do they present? They present at puberty, because that is the age of maximum growth. And therefore, they all present to adult nephrologists needing dialysis. You will never see them. So what we are doing today is pushing them between 15 to 30, needing dialysis and transplant to the adult nephrologist. So that has to change. We need to start picking them earlier, because we can maintain kidney function for a longer time if you pick them earlier by doing a simple 80 rupees test, which is a serum creatinine, and calculating the estimated GFR. So that's the message. The second important question is the symptoms. You do not get any symptoms. You will not even get signs. No hypertension, no growth failure occurs till your GFR is 30 ml per minute. You are never going to pick these children up with signs. Third important question, लघवी व्यवस्थित करतोय ह्याला काहीच अर्थ नाही आहे, because you normally filter 144 liters of blood to produce 1.5 liters of urine daily. So when your filtration drops, when your GFR becomes 10%, you are still filtering 14.5 liters of blood. To produce 1 liter of urine is very simple, because the tubules have gone a problem, and the concentrating ability is lost. So your urine output will never drop. So if you are going to look at symptoms or signs, you have missed the boat. So we need to start picking these children up early. A simple creatinine and an estimated GFR will help you in diagnosing these children early. Thank you.
Thank you, sir, for very practical tip about the renal diseases. Yes, someone was saying something.
Dr. Pankaj sir, I want to ask
Yes,
you
yes.
3 questions. Very important, I
Yeah.
think. Number one,
एक का चार.
तीन.
Okay.
तर पहिला प्रश्न असा की more often told in webinar, attending webinars, कसं urine sample लगेच पाठवायचं आणि लगेच करायचं. But fact remains, ground reality remains. So whatever we insist, still the urine sample is not processed immediately. So rather pursuing this urine routine, is there any way out to detect urine infection? That is the first question. Because in spite of telling lots to lab, they do not process most of the time. What is the way out?
Correct. In fact, urine infection is a completely different ball game. So if you look at the first thing you need to look at is symptoms which the child presents. So if a child presents with fever and urinary symptoms, the likelihood of a urine infection is high. If a child presents with fever and cough, why would you do a urine sample? Which is what we are often doing at present. So that needs to stop. Thirdly, a child having only fever without any urinary symptoms, so fever without focus, 95% chances viral ahe. urine infection nahi hai. Even if you see pus cells in the urine, it may not be a urine infection. So I think the what we are saying, that delayed sample or whatever is being picked up. Yes, for example, if you pick up nitrates in a child who's coughing, ignore that. If you pick up pus cells in a child, that if the symptoms correlate with the urine infection, act upon it. If you don't see pus cells, don't call it a urine infection. You can wait. It's as simple as that.
So no, the point was that whether any dipstick is there, whether we can do in our setup clinic. Dipstick
As
is
long as you are aware of false positives, false negatives.
yeah, okay. The second question is that means you said ki creatinine should be done in the children because you cannot diagnose early. So is there any suggested interval after means once in a year or after 6 months, and whether doing only creatinine will help us diagnosing that it is progressing towards chronic chronic kidney disease?
Now I will ask you one question. When was the last time you did your creatinine, Dr. Gangolia?
Last year.
So adults also should be doing creatinine once a year. हे सगळे इन्शुरन्स वाले जे करतात एका वर्षात काय टेस्ट करतात हेच तर करतात. Creatinine once a year should be done even for children. Why not?
Yes.
We do so many CBCs. एक creatinine करा 80 रुपयाचा काय फरक पडतो त्याला?
Okay.
So a creatinine is important. More important than the creatinine is the protein creatinine ratio, which I keep on talking, but that we'll talk about some other time.
Okay.
But you have to start at least because creatinine is the last thing to go up even when your GFR drops. But let's start picking up at least at that stage.
Yes.
Because they are not symptomatic. They are not symptomatic at all. You will be very surprised to find the creatinines. So one of the things which I was going to again, तसं बोलत बसलं तर तासभर लागेल. But for example, a child, and in the antenatal scans, if we have got oligohydramnios, how many of us check a serum creatinine for the baby after birth? Nobody does. The child is passing urine well, looks well, ghari paathoto. Now these children are the ones who are going to present to the adult nephrologist after puberty. So what have we done in the pediatric age group? Sardi खोकला treat करून काय मोठं केलं आपण त्यांच्यामध्ये? When we knew there was oligohydramnios in the antenatal period, we should have picked up a creatinine. And if you say I'm going to do a creatinine at 6 months, it will be normal. It's only in the first week that it may be abnormal. Then you will start getting proteinuria later on in life. So आपण हे दोन्ही pick up नाही केलं तर these children are going to present to the adult nephrologist. So that's what we need to stop.
And last question is EGFR, whatever the norms are there, or means what is the pattern graphs?
The constant, म्हणजे the constant value changes.
Yes.
So it has varied through time. For Indian children, it is considered as 0.413 as it was put in the presentation. So you can use that for all of them. Remember, in neonates, your GFR itself is low. So 0.413 multiplied by height divided by creatinine. थोडंसं कमी येणार तेव्हा उड्या मारायची गरज नाही. But after 2 years of age, it should be more than 80 ml per minute.
Yes, sir. So very important message. Tomorrow, everybody one is going to do creatinine and sending the reports to Dr. Pankaj sir.
नुसतं क्रिएटिनिन करून प्रोटीन क्रिएटिनिन रेशो पण करा म्हणजे कळेल काय गडबड चालली आहे.
Yes, Renu madam. Yes, Renu.
Yeah, Nandita ma'am. Yeah.
Thank you, Gangolia sir. Thank you, Pankaj sir. Now we are at the end of our today's Tuesday text. Thank you, Maha IIP and Women's Committee. Yes, sir.
Madam.
Yes, sir.
Ramakant.
Yes, sir. Yes, sir. Welcome,
Yes, sir. Yes, sir.
I have got a question to Deshpande sir. We are hearing it time and again that missed pyelonephritis, particularly in infantile or early childhood, which is the cause for dialysis in the 4th or 3rd decade, 5th decade. At the same time, you are saying that we are unnecessarily doing the urine test because in infants, when there is a fever without focus, and particularly in recurrent fever without focus, and constipation history may be present or not. So this becomes a slightly dichotomy. At one side, you are saying that it is not to be done. And other side, we are hearing that recurrent pyelonephritis is there and we are missing it. And probably that is the reason we are getting more and more mid-age renal damage. So,
So
how
can I
will you
answer?
decode it?
Can I answer? Karu ka main?
Yes, please decode it first.
So if you go back to data, let's say in 1980, okay, 1980 end stage renal disease, the commonest cause was pyelonephritis, 70% in children. By the time 2000 came, that incidence had gone down to less than 10%. Why? The incidence of renal dysplasia had gone up proportionately. So what we were treating as pyelonephritis was not necessarily pyelonephritis. They were born with abnormal kidneys. If you get a single urine infection in a perfectly normal kidney, it's unlikely, yes, you will get damage. It's unlikely you're going to reach chronic kidney disease. Whereas if you have damaged kidneys, whether you get urine infections or no, you are likely to go into chronic kidney disease, which is what I said. If you have oligohydramnios in the antenatal period, you have got dysplastic kidney. Dysplastic, remember, are not hypoplastic. छोटे नसतात, नॉर्मल असतात. पण त्यांच्यामध्ये काम करण्याची क्षमता कमी असते, नेफ्रॉन नंबर कमी असतो. And that is why they are perfectly normal during childhood. But as they reach puberty, which is the phase of maximum growth, the kidneys cannot sustain that growth, cannot provide for the adult body, and therefore they go into kidney failure. So the myths that it's acute, that silent pyelonephritis असं नसतं काही. There have to be symptoms. What we are missing is renal dysplasia, and that these are children who are perfectly normal attending school. So if we don't pick them up, our thing will continue. आता आपण UTI ट्रीट करून 25-50 वर्ष झाली. इन्सिडन्स ऑफ CKD कमी झालंय का? नाही झालंय. 3 लाख लोक अजूनही डायलिसिस चालू करतात एडल्ट मध्ये दरवर्षी. Where has it changed? Because we are missing these. So we need to start picking up renal dysplasia in children. That's the message.
Okay, so that means we are not really missing pyelonephritis, but we are missing dysplasias.
Yes.
Okay. And one more question, if you allow, and if the office bearer.
मला वेळच वेळ आहे, बाकीच्यांना विचारलं पाहिजे.
Sure, sir. You can ask. Yeah.
Thank you for that. This thing. What is being said that now with nitrites and this thing after the 1 year of age, this really holds true unless until there are symptoms. We shouldn't be doing any leukocytes and esterase and nitrites. But is it true that below 1 year of age, if you are getting fever time and again, and as Gangulia sir has said that many times collection of sample, processing and seen by pathologists, many times this cell lies. And so will it be a good screening test for at least for infants to do simultaneous leukocyte esterase and nitrites? And if there is fever, of course, fever without focus, without
How
any
many
respiratory
days?
symptoms. If
How
any
many days of fever?
Of course, the fever which is last for 3 to 4 days, more than 4 days. Because if on the day, if the fever is there, and if we do not have any prodrome, rhinorrhea, cough, and if there is no rash, and no pointers to suggest that this is a viral infection, but a child is still definitely has to suggest fever. In these cases, particularly infants, if there is no respiratory prodrome, how far this leukocyte esterase as simultaneously being done nitrates holds water?
I would still go back even one step further. Is it a well child or an unwell child?
Yeah, of course, when day 4, child will be unwell. But
no, if the child is unwell, why would you wait 4 days?
See, whenever
you have to different. No, listen. You have to differentiate between a well child and an unwell child. The problem is the guidelines are not telling you that. If you read American guidelines also, there's a clear distinction between a child who looks well. In fact, they say very clearly, a well child, you can follow up till the fever disappears without even thinking of a urine test. हे कोणी वाचत नाही, पुढचं फक्त वाचतं सगळे. But in an unwell child, if you think the child is unwell and your judgment is the best, because you see far more sick children than anybody else. If you think the child is unwell, then it should be done on the first day itself. Why wait till the fourth day?
Because on day one, if there is no history suggestive, I will definitely refrain from doing it, because day one, I'm not sure I will be doing only at all if the peripheral smear and if there are symptoms suggestive of urinary infection, then and then only. But what about in infants?
No, but
We
if
will
the
not
child
be
is
able
sick,
to know.
if the child looks sick, you will not wait.
See,
How will you wait?
with doing paracetamol on day one, child may not appear sick in between the fever.
So whenever the child appears sick, you have to do the test soon. You cannot wait then. If the child looks well, then it doesn't matter what test you do.
Okay. But what is
No,
your final?
You are a far better clinician than anybody else in the world. So I think that's what the message is.
What is finally your take on this leukocyte esterase and nitrite? Should we be doing it or not simultaneous?
It is just like any other test. Whether you do a urine routine, a urine culture, or a leukocyte esterase and nitrite test, all are equal. As long as you look at the child, the symptoms, and correlate what you find. Just like I presented in Mahapedicon, you have a child who's got fever without focus. You have done a nitrite test, but if the bottle has been opened repeatedly and the sticks have been exposed to air, within 2 weeks, most of the 50% of the sticks will start reading positive even when it's not positive. So as long as you're aware of the false positives that come up, you can do any of those tests.
And what should be the ideal method of urine culture? Is it still the midstream urine, catheterized, or the suprapubic puncture that we do only below 3 months?
Again, each of them has its pros and cons. Midstream or a clean catch urine sample is the most convenient sample. As long as you explain how the sample has to be collected, very often what happens is you tell them to go and give a urine culture. They go to the lab and give the culture. So unless we explain how it has to be collected, it doesn't get collected properly. And then we get into a circle of getting erroneous reports. But I don't necessarily advocate a catheter sample unless you are really hard pressed for it. A midstream remains the commonest way of collecting urine samples.
And last question, sir, whether the colony count remains same for all the organisms. I'm not saying about the sample. I'm not saying about suprapubic or catheterized or midstream. I'm saying about the bacteria grown. Is it the colony count significance is the same for all across organisms, or it is variable for organisms?
Again, it depends on the symptoms. If you get a colony count of 1 lakh of any organism in a child who's well, it is to be thrown away. So unless everything fits in together, the child has symptoms, child has fever, you suspect a urine infection, you collect, you get pyuria and then a positive culture, then we consider it as a urine infection. American guidelines say 50,000 count is enough. We are still saying it should be more than 1 lakh. For this, you need to go back to why 1 lakh was chosen. I think, as I said, gappa marat basayla mala problem nahi hai, but aise chalu rehna hai. Because if you went back to why they said 1 lakh colony count should be present, when they first started putting these plates on agar and everything else, they found that when there is an actual infection, 1 lakh easily grow hote. 1 lakh was without even consideration of the number. So the lowest number which was easily grown in a proven infection was considered as a significant colony count. So 1 lakh is very easily grown, and therefore that has been the number that has been selected.
Thank you, sir. Thank you for elucidating so well. Thank you so much.
Yes, sir. Ramakant sir जिथे सोडलंय तिथून एक अजून sir, Dr. Pankaj still 94 are watching you on the Zoom. And I do not know about YouTube, but 94 are still present. So they are really interested. They are not interested for MMC point, but they are really present there. मला असं म्हणायचंय डॉक्टर पंकज सर की बऱ्याच वेळेला पीडियाट्रिशियन कडून पण हे बोललं जातं की डे 1 ऑफ द फीवर वी शुड नॉट मिस युरिन इन्फेक्शन. बरेच जण म्हणतात की पहिल्याच दिवशीच युरिन रुटीन करा. So now questions come whether to do that in view of 2 things being said by you. One thing, child being unwell or the symptoms of dysuria. which is very difficult to know in the infantile age as well as the lower age group. So how do we go about?
I can give a very simple answer. पुढच्या महिन्यात माझं article येतंय, so you can read that. But the simple answer is, I think, in fact, there are going to be guidelines given out by ISPN also, which are different. But I think if you get a urine sample, if the child looks well, and if you get pyuria, what I am suggesting in my algorithm is don't start antibiotics, wait till the culture comes back. And if the fever goes away without you starting antibiotics, it's very unlikely to be a urine infection. Whereas if the culture comes positive, the child is still spiking, or the child becomes ill at any point, you can start antibiotics. Next month येईल.
So now listening to you.
कुठे IP मध्ये का सर?
नाही जर्नल मध्ये. I'll send it when it comes. सगळ्यांना पाठवतो.
So listening to you sir ना, मला असं आत्ताच एक आयडिया क्रॉप झाली आहे. कदाचित आपण असा वेबिनार चालू करूया तिथे काहीच नाही, टॉपिक वगैरे काहीच नाही पाहिजे, फक्त स्टार्ट नेफ्रॉलॉजी सेशन आणि प्रत्येकाने आपापले क्वेश्चन विचारायचे, लेट अस गो अबाउट इट. मग त्याच्या प्रॅक्टिकल क्वेश्चन्स बऱ्याच वेळेला सॉल्व्ह होतात रादर दॅन लिस्निंग टू द टॉक्स. आय थिंक सो. लेट मी क्रॉप दॅट आयडिया.
You're welcome.
Sorry, Madam Inita and Renu for interrupting lots of time.
No.
sir.
This is
Thank
open
you,
for,
sir.
it was an open panel for
Yes.
discussion. Yes, now we come to the end of the session. It was very much brainstorming for the last 10 minutes for all the delegates also. So it is a teamwork that we did along with the MAHAIP and the MAHAIP Women's Committee for the last 10 Tuesday takes. For the team coming together, keeping together in progress, and also working together for success. So a heartfelt thank you to MAHAIP President Dr. Gangolia sir, Dr. Amol, who is our Secretary General, and also the core team of MAHAIP Women's Committee, all the zonal coordinators. I thank to them from the bottom of my heart for being with us for the last 10 sessions and conducting it very successfully, reaching all the unreached people of Maharashtra. Today, I take the opportunity also to thank our EB, Dr. Ramakant Patil sir, who is present here, and also our OBs and EBs who were there, Dr. Sadavarte sir, Dr. Jai Kumar sir, and others. Now, it was a great academic discussion by our stalwart experts, Dr. Pankaj Deshpande sir and Dr. Pankaj Bansali, and also they guided our speakers in the last 8 days for their PPTs, and also we are thankful to them for giving us the experts pearls for today's top discussion, and thank you for accepting our invitation. All our dynamic young speakers of today's Dr. Parulekar, Dr. Pawan Deore, Dr. Deepa Maitre, Dr. Vinod Ingre, Dr. Srirame, Dr. Sharvari Rathi. We thank you to take the challenge, for accepting this challenge and also coming on this platform and giving an excellent deliberation. MMC observer of today was Dr. Sanjay Gosavi. We acknowledge his presence and thank you, sir, for being a MMC observer. Our moderators, Dr. Jayashree Shivalkar ma'am from Nagpur and Dr. Neeta Hatkar from Dhule. I really appreciate their efforts for last 3 to 4 weeks. They have been very, very committed to this Tuesday Takes 10th edition, where they have, with the help of the zonal coordinators, they have searched for the speakers, they have taken up the topics, they have coordinated with all our other delegates as well as the judges. And we thank both of you, ma'am, for excellent moderation today. Our core team of Dr. Sonali Shirvate, who is the co-chairperson for the Women's Committee, I thank her. Also, Dr. Neha Singh, our editor, MAHAIP, and Dr. Vishal Raut, the digital wizard of our MAHAIP, for all the flyers, and Pallavi Dharmadhikari, madam, for the today's digital coordination. Last but not the least, all the pediatrician colleagues who have joined today for and being there till the last, listening to all the discussions. I thank all of them and also ask them to be there for all the MAHAIP program. Please do like our YouTube channel MAHAIP. Please subscribe to it. You will get all the videos of last 400 about programs which has been done by our MAHAIP president and secretary on the YouTube channel. Please go through it. And also we will meet again for the next month for the third Tuesday of the month for the Tuesday takes. Yes, Dr. Pankaj Bhansali, you have appeared now. Do you want to have your expert comment as a last comment?
Actually, it is very good function. Honestly speaking, very few occasions I could attend it, but short and crisp and covering most of the important topics of every specialty. It's really wonderful program.
Yeah, thank you, Dr. Pankaj Deshpande sir, Dr. Bhansali sir, and Dr. Gangolia sir. Do you want to have a word? Yeah.
No, well said. Hearty congratulations to MyIP1 committee, and do spread the message of sharing and subscribing MyIP YouTube channel in your local branch groups as well as in your pediatrician groups. Please do that. Thank you very much.
Thank you. Good night, one and all.
Thank you. Good night.
Pallavi madam, live streaming बंद करो.